Today I'm going to be talking about the topic of overdose prevention, as Randy said, and we'll talk about lots of different topics, including naloxone and another new resource that I'm excited about called Never Use Alone. And just as a quick introduction, I'm an assistant professor at the School of Nursing. This is just my second year at UW-Madison, so I'm like a during COVID hire, still very much meeting people and excited to be with you today. Yeah, so I like to start my talks with just kind of like orienting a little bit about who I am and kind of what my research is. So today we're going to talk a lot about overdose harm reduction. Some of the other research interests that I have are around substance use treatment, HIV and hepatitis C prevention. I am actually not a nurse by training, though I really have enjoyed my almost 2 years at the School of Nursing here. I'm an epidemiologist by training, and I'm trained in public health. And some things that I'm sort of working on as an early career researcher, or topics that I'm excited about, are technology-based interventions and implementation and dissemination. So I'll talk a little bit about how my research uses some of those kind of tools as I've joined UW-Madison, which certainly has a lot of excellence in these areas. Okay, so yeah, today we're going to mostly focus on overdose prevention research. Instead of focusing on one particular study that I'm doing, I kind of thought it might be fun to do kind of like a whirlwind tour. And then if there's any topics that we want to discuss more deeply at the end, we can. And I'll just throw in a little bit at the end about some next steps that I'm thinking about and where I think my research will go. So many of you are probably familiar with graphs like this of overdose mortality rates, which have generally been rising in Wisconsin and nationally since about 2000 or a little bit earlier. In red here, you're looking at opioid overdose deaths, and in black, all overdose deaths in Wisconsin. And really, you know, though the trend is rising, we saw a particular increase during the start and throughout COVID. So in 2020, for example, relative to 2019, there was a 27% increase in overdose mortality in Wisconsin. And we saw this trend nationally as well. Here plotted as the last dots are actually provisional data from 2021, not all the way through the year yet, just through October. So looking from October 2020 to 2021, and it's looking like we're going to have some other increases this year as well. So a really serious problem that's only been growing and kind of demands creative strategies to address. So many of you probably know that synthetic opioids other than methadone, primarily fentanyl, are driving overdose deaths in Wisconsin and nationally. This is national data looking at overdose deaths in the US. And that blue line that goes up really sharply is overdose deaths due to fentanyl. In the last couple of years, we've also seen some increases in stimulant-related overdose deaths. So there's a line in gray that's sort of gone up in 2020, and then another blue line for cocaine. So that's certainly something that people are becoming more and more attuned to, that we really don't just have a problem with opioids, but particularly with fentanyl contamination of the stimulant supply and perhaps even increased use of stimulants. We may be seeing a continued rise in stimulant overdoses as well. So a topic that I'll spend quite a bit of time on today is naloxone, which probably most of you know what that is. It's an overdose reversal medication that is available through pharmacies and many community resources. Administering naloxone can rapidly reduce reverse the respiratory depression of an overdose. And so it's a really effective tool. If someone encounters an overdose and is able to administer naloxone, it's a really effective tool in saving someone's life. I would say over, the late 2010s, we really have seen an encouraging increase in naloxone prescribing and naloxone distribution. So it's becoming more and more available to community members and people who use drugs themselves and many others. So for example, one study showed that, in between 2017 and 2018, there was this huge increase in naloxone prescriptions, which was definitely encouraging. Though it is clear from data that we're kind of falling short of addressing both overdose mortality and our need for naloxone prescribing and distribution as well. So I just told you that, naloxone is becoming more available. It's a really effective tool, yet the prior graphs that I showed really suggest that we have continued to have major issues with overdose mortality continuing to rise over the last several years, and particularly since COVID-19 there have been some really sharp increases. So in kind of thinking about my research, I try to ask myself, like, why our current tools might be kind of insufficient. So when we think about naloxone, for example, one natural explanation is that just the amount of naloxone that's being distributed is not meeting the demand or the need. And certainly some studies have looked at this. For example, this one suggested that rather than the 500,000-ish naloxone prescriptions in 2018 that were dispensed, we should have seen about 9 million just to cover kind of people with high dose opioid prescriptions. And that's not even saying anything about people who need naloxone for other reasons. So certainly some evidence that though naloxone is an effective tool, we're not quite getting it out there enough. Other reasons that overdose mortality still is rising probably relate to a lot of missed opportunities to provide naloxone or other overdose prevention tools. So this study in MMWR in 2020 really looked at, like, among overdose deaths from opioids or stimulants in the US, what potential opportunities were there to intervene where naloxone could have been provided or another tool. And as you can see on the bar graph here, in many cases, though not all, there was certainly the potential for some type of intervention or conversation about overdose and perhaps an opportunity to provide naloxone. But even when we think about naloxone and overdose in general, some overdose situations are just not going to be, the risk is not going to be fully reduced by having naloxone available. So in this paper, they did a really nice job of looking at what percentage of overdose deaths there was strong evidence of having a bystander present, which is very difficult to determine, but using death records, they estimated that about 40% of overdose cases or overdose fatalities had a bystander present, which leaves about 60% gap where there was no one there who could have witnessed the overdose and administered naloxone quickly or called 911 or facilitated another response. So in these situations, which I'll kind of circle back to later in the talk, it's clear that just giving someone naloxone is not going to be sufficient to save their life. And then finally, kind of harkening back to the graph before, we also know that there's fentanyl in the drug supply. This has really been, recognized during the COVID-19 pandemic as well as a potential reason that overdose deaths have really sharply increased. And as I mentioned before, a lot of concern that fentanyl is now showing up in the stimulant supply as well. So lots of potential opportunities for improvement when we think about how can we reduce overdose mortality. So I want to come back to kind of in this first segment of the talk and focus a little bit more on naloxone. So kind of coming back to this missed opportunity to provide naloxone in this MMWR from 2020, there were two places where about like 20 to 30% of people visited before they had the fatal overdose that led to their death. And these were places where they got some type of mental health diagnosis or treatment, and places in particular where they got substance use treatment. And this really kind of goes in line with a recent recommendation made by ASAM that naloxone should be provided to patients while they are in treatment for opioid use disorder, and also consider providing naloxone for patients, family members, significant others, et cetera. This sort of highlights that, not only is this a missed opportunity, but it's also a practice recommendation, and, kind of begs the question, has this recommended practice actually been implemented? The reason to provide naloxone during treatment is pretty clear from studies of overdose risk in the early treatment period and after. So this is a study by Sordo et al. That summarizes people's overdose mortality rates when they first get into treatment on the left, as well as when they stop treatment. And really what we see is kind of like, as you might think, tolerance is lower as you are using fewer drugs or maybe in a treatment program. And so overdose mortality tends to be elevated in that time since getting out of treatment, particularly in the first couple of weeks or month after treatment. Again, highlighting that treatment could be that critical time to kind of intervene, provide naloxone, provide some education or some other risk reduction tools. We also know that naloxone awareness could be kind of another barrier. So do people who go to treatment know a lot about naloxone? I did a study while I was, was during my postdoc, where we really just wanted to know how many people in a study of a group of people receiving substance use treatment in Michigan were aware of what naloxone was and why it was used. And we found that most people who used heroin really had a lot of awareness about naloxone, about 83%. But those who were using prescription opioids and were in treatment for that really didn't have much knowledge. So certainly treatment is yet another time to do some education as well. The last kind of piece that we could do some education around in treatment or elsewhere is around carrying naloxone. So this is a study in Baltimore looking at a totally different group of people who inject drugs, many of whom said that they had received naloxone, they had even administered it to someone else, but less than a third actually carried their naloxone often or always on their person. Or had it around them commonly, meaning that, you know, they may witness an overdose and not actually be able to use their naloxone. So with all of this kind of background in mind, last year when I first got to UW-Madison, I was part of a team that established what we now call Project Send It, and we applied for an ICTR C-Corps award. So I'm going to spend a little bit of time today talking about that work. And SEND IT stands for Safety Enhancement Through Naloxone Distribution in Treatment. So as the study title sounds, this was really a pilot award where we looked at what are some strategies that we could implement to help treatment organizations actually start distributing naloxone. Oops. Again, this work was really, it's an implementation science kind of pilot study. So what we really wanted to do was understand what the best practice recommendations were. I mentioned one from ASAM before, and this is another, and then see how we could implement them. So another set of recommendations that were really key to us in trying to develop strategies were from this report out of the CDC in 2018 that really looked at some recommendations for how naloxone could be distributed. So some key ones that we were interested in kind of designing our program around was making this an opt-out over opt-in program, really incorporating a non-stigmatizing approach, trying to incorporate family, friends, or partners where we could so that those people who might actually witness the patient's overdose, if it happens after treatment, were trained to know where their naloxone was and how to use it. And then really look at how can we have a kind of a solid source of naloxone that could be distributed in treatment and have that paid for. So the main goals of Project Send It were to really get a good understanding of the barriers and facilitators to distributing naloxone and substance use treatment. We did this with qualitative methods. And then we really hoped to identify strategies that would work in different clinical treatment environments. So the particular community partner that we had was really interested in not only implementing naloxone distribution in their residential program, but also in their outpatient program, their detox center, their transitional housing program, and several others. So really to kind of think about what different strategies do we need by the different treatment model that's being used. So when we did this study over the course of a year, it actually just ended March 31st. And as I said, we used qualitative methods for the most part. So in our first aim, we did 10 in-depth interviews with leaders of a treatment organization that we partnered with called Tellurian, which is in Dane County in Madison. So we interviewed a variety of people, leadership at the organization, people who were the head of each unit, the providers who would maybe be writing the standing order for the facility for naloxone. And we even interviewed the IT person to kind of talk about like how would this fit in the EHR. Then from there, we did 6 focus groups with different treatment units. So the ones that were included were the detox center or treatment readiness center. They have a case management program for people who are receiving medications for opioid use disorder, transitional housing program, a crisis center, residential program, and an outpatient program. So lots of different settings in our study. And then the final step was to really get patients' thoughts about what they wanted to see in a training. So we interviewed 10 patients And then I had a doctoral student who I'll tell you about in a little bit, who also did kind of a pilot test of an overdose safety planning and naloxone training session. And we did provide naloxone training and distributed naloxone to the patients who were in our study too. So this is our wonderful team. And I just want to quickly highlight Gina Bryan, who is also at the School of Nursing. She really helped me co-lead the study and also works as a provider at the study site where we work, Tellurian. So she was just such a great partner. And then a whole host of students who helped us, as well as many others. Several faculty on campus, including Randy, helped with writing the study, and I hope will help with synthesizing some of the results now that we are actually in a place where we have data. And like I said before, this was supported by an ICTR C-Corps award that just ended March 31st. Oh, and last, I'll just again acknowledge our community partner, Tellurian, who was so gracious in letting us collect data from their patients and their staff. Okay, so I'm just going to go through a few kind of preliminary results and what we found. We just finished collecting data, so nothing is super well synthesized yet, but I thought I would share what we have so far. So the way that we set up the focus groups, and we structured the interviews this way as well, was to kind of help people or give people sort of a framework for thinking about how could we provide naloxone. So we identified 3 key steps: screening for who needs naloxone, training patients to use naloxone, and then distributing. And in each unit-specific focus group, we really asked people to walk through how would you want to do this process, and then what challenges do you think we could run into that our team can help kind of think through or do some research to kind of develop strategies around. So we came up with a lot of really practical results. Honestly, nothing earth-shattering, which didn't surprise me, but I think the strength of this study is really in getting all of these strategies on paper so that they can start to become a formal protocol. So just to go through a couple, for screening, we really found that overdose history was not consistently assessed. Most people said, usually when I'm doing intake or something like that, it's a really busy time. I have a lot of questions and a lot of processes I need to go through. So most of our staff really suggested something simple to open a conversation about naloxone, which they weren't having at present. But something as simple as asking someone if they know what naloxone is, or if they have an interest in getting naloxone, might be a good way to kind of open up a conversation about who might need naloxone and get a little more information about overdose history as well, which just wasn't consistently happening when we started the study. In the train step, people mostly said, I need training to provide patients naloxone training, and patients obviously need training too. It wasn't just training that they felt they needed, though. They also, this quote kind of says, you don't just need how to use naloxone. You also need to tell people who needs it, what sort of drugs does it work against, what does an overdose look like, and where somebody can go if their supply expires or if they need more, or something like that. We did in AIM-3 implement a curriculum that DHS developed called the Train the Trainer curriculum, and several people on my team, including myself, took that kind of in preparation, and that definitely provided us a really good baseline with some of these elements that people were certainly wanting. And then finally, on the distribute step, each unit sort of identified different times where it would be the optimal time to hand out naloxone. There was one person said, building this into discharge is the perfect time because I will do everything on the discharge list, for example. But that was really only appropriate for programs that had a specific discharge date, like residential or detox. It wasn't going to be as workable for an outpatient program where that's a bit muddier and the relationship tends to be longer. Most people said, though, in any of the sort of programs where people were staying at least for a few days, that they especially worried about patients leaving against staff advice. So kind of having some special strategies around those situations was something they wanted to see. I figured I would just go through a couple other key insights and kind of just interesting things that came up in our interviews. So one is something you might have heard of before, in the lockbox, or a confidential way to distribute naloxone. One participant what we were kind of having a frank conversation about stigma, which is sort of a theme of this slide. And one participant in a focus group really said, it'd be great if there was, a box, in this quote, a box of naloxone next to the soda machine. I don't know if that's the right thing to do, but I think for some people, they'd be afraid to take it. They'd kind of be afraid to be treated differently or be labeled as someone who needed naloxone. So having that confidential supply might be something for patients who are, just a little bit reticent to have that conversation more publicly with their provider. We also had a ton of good analogies come out. So we had, again, a lot of conversations about stigma and how naloxone could kind of be destigmatized or normalized. So one quote here is about how you can think of naloxone like a first aid kit, and how just because you have a first aid kit, it doesn't mean you're planning on falling down a hill, but you might need a Band-Aid. And someone else said it was like a fire extinguisher that you can have in your house, which doesn't mean you're going to start a fire because somebody else could. And then a couple of other really good quotes about why we really need to directly distribute naloxone instead of prescribing it and making people kind of go pick it up on their own, or recommending that they picked it up or something like that through the state standing order. One person really analogized this to going to the dentist. So they said, you don't go to the dentist and they tell you to go to Target and get your floss and get your toothbrush. They give it to you so that you have a toothbrush when you get home, because otherwise you might not do it, and then it's not going to save your teeth. So again, just some really key insights as we talk to staff about, how to kind of make the case that this was a practice worth doing, and how to destigmatize it as well. Okay. We also did some work with patients. So I'm just going to tell you a little bit about work done by my student, who is a DNP candidate. She'll be graduating next month. And she did an overdose safety planning pilot study with a naloxone training as well. So I'll tell you a little bit about that. As I mentioned before, we use the Train the Trainer, or Training of the Trainer naloxone education curriculum developed by DHS. Anyone can take this if you're someone who's kind of interested in being able to train others to then train patients to use naloxone. I definitely recommend it. It's either 2 or 3 hours and free through DHS online. And essentially we developed like a 10-minute training for participants in our study based on this. So we went through a couple of handouts that DHS developed, kind of hitting the high points of the training, and then they really got time to do hands-on practice with a mannequin. Part of the Train the Trainer is they send you actual Narcan trainers, so people can practice depressing the button into like the mannequin's nose, practice using a rescue barrier that we also handed out. And then we gave them a video as well that they watched that's about 2 minutes, also through DHS. And at the end, they got this little kit that's pictured here with naloxone, rescue breathing, barrier, and some other resources. So when we did, we kind of incorporated the naloxone training with an overdose safety planning intervention, which I'll tell you about in a minute. We of course had our own study process too, and I guess the keys to note on here are that we did both a pre and post test to actually look at whether people were picking up what we were saying about naloxone and whether our 10-minute training was sufficient. And then we actually had them do some debriefing on overdose safety planning as well. This was something that we sort of designed based on some other resources, so much more formative, and we just kind of wanted to get some initial feedback on what people thought about it. So a little bit more about the overdose safety planning that we did. My student designed this worksheet that is on here based on a number of other safety planning resources. You might recognize safety planning from suicide safety plans, which are an evidence-based intervention to reduce suicide risk. And so recently there have been, numerous like health departments and others who have developed kind of this idea of the overdose safety plan. And we took a bunch of existing resources, and then my student kind of adapted them to fit our needs for the treatment setting. And so people go through several kind of components related to what to do when they, are having cravings or early warning signs that they may begin to use. And then they receive a little bit of information about some, important numbers. And then towards the bottom, some more like harm reduction oriented content around if I end up using, how I want to stay safe, where I can keep my Narcan, who I'm going to tell where my Narcan is, and whether they know how to use it, safest settings for use, and places where I can get more Narcan or clean and sterile injecting equipment too. And just to highlight, there's a ton of other overdose safety plans that could be, really key for other settings as well online. This is one that I really like. So I just kind of put a picture of it here that helps someone just kind of walk through some of the more focused kind of overdose safety planning steps that they might want to consider. So we were glad to see that despite our relatively brief naloxone training, there was definitely evidence that knowledge and confidence scores increased. We used the OOCS to assess this. So people generally reported having more confidence about their ability to respond to an overdose. They recognized overdose signs and symptoms more accurately. In a couple cases, the knowledge that we assessed, those scores were high before training, though they tended to increase, but certainly some evidence that the folks that we were training already knew a little bit about overdose and naloxone as well, which wasn't surprising. Maybe more importantly, everyone that we interviewed and worked with in this project said they would recommend the training to others, and that they really thought this belongs in treatment. This is, we were a little bit unsure at the start of this study whether patients would want to engage with this material at a time where maybe they have some goals around sobriety. And especially because it hasn't typically, maybe been a part of the treatment that they've received at Tellurian at least. But pretty consistently people said, I want this to be part of my treatment program, and it would be even better if something like, with incorporating family or friends or something like that. We also got some feedback on overdose safety planning. So we wanted to know, like, was this resource that we sort of had the researcher and the patient work through the worksheet together, was this helpful for them? For the most part, we got some pretty positive feedback. People really liked that kind of partnership with the therapist and the provider. My student is a nurse, and she's she's training in psychiatric and mental health. And so she very much, approached this from kind of a therapeutic lens in the research too, which I think is kind of a strength because, hopefully this would be a tool used by the therapists at Tellurian. And there was certainly some interest in that when we shared these results with them a couple weeks ago. So certainly this provided kind of a structured opportunity for the person to work with their therapist or provider. And they had a couple of recommendations for how to make the tool better, which was great. But most really said, I'm comfortable with this. This is something I enjoy doing, I would want to do. So lots of good feedback. Just to kind of wrap up a little bit on this project, there's a lot of challenges to implementation that have kind of remained or maybe become more well described from this project, but do remain challenges. And the big one is really, how can we sustainably fund supplies of naloxone to distribute? In our study, we had some funding to do this, and we also had some support from local public health as well. And certainly made some connections with DHS, but the process of getting, a sustainably funded supply of naloxone to distribute on site is a lot more complex than just, partnering with public health and having all covered. So certainly more to learn there. Another big challenge, of course, as with all substance use research, is stigma. We were, I guess, encouraged that patients, the people that we interviewed at least, they really didn't report that they would feel stigmatized from being asked about overdose or asked if they wanted naloxone in treatment. And in fact, they wanted to have these conversations with staff, but they did say a lot about feeling or anticipating stigma from family or friends or community members if somebody found out that they had naloxone on them. And then finally, we uncovered a number of misconceptions in our work. So just kind of misinformation, people thinking one thing that wasn't quite correct. So one that came up a lot in our interviews was actually that the way you administer intramuscular naloxone is like in Pulp Fiction, when you like stab someone in the chest with a needle, which is obviously not safe and not correct. So luckily, we were able to talk them through that. but certainly, you know, some misconceptions arose that anyone doing the naloxone training would have to be ready to talk through. Okay, so next steps, we're still really doing this analysis. We just wrapped data collection on the project, but hope to have a summary of recommendations about naloxone distribution to share at the end. And I just kind of put at the end, in case I'm not quite sure who's in the audience today, but if anybody's kind of looking for information on like where to get started learning about naloxone, or getting an organization kind of ready to distribute naloxone through the Narcan Direct program at the state, these 3 places are great places to start. And I'm happy to talk about anything as well. And in fact, my student is probably the most expert of all, so happy to connect anyone with her too. Okay, so yeah, doing okay on time. So I'm going to switch gears just a little bit and kind of jump back to this discussion we were having earlier about just drivers of overdose mortality, and kind of this situation where, you know, if a bystander is not present at an overdose, naloxone is like wildly insufficient to saving a life or reversing the overdose. Yeah, I guess just to kind of frame our thinking a little bit about this, when I was training, one of the papers that really kind of got me thinking more about this situation where someone is using alone, or they overdose and no one is there, or no one's within earshot. This commentary is an excellent one. I recommend, like, you know, if you're interested in the topic, this is a great place to start. But yeah, this paper is titled "Dying Alone: The Sad Irrelevance of Naloxone in the Context of Solitary Opiate Use." So, sir, this has certainly become kind of a research direction for me, in terms of asking, like, how can we support people who are using alone? And just kind of a quick, I showed you one study where, you know, about 60% of overdoses were involved no bystander. This is relatively consistent with other studies of fatal overdoses. Of course, this is kind of difficult to characterize whether there was a bystander at an overdose, because we know that people sometimes fear getting arrested, so someone might flee the scene. The data that we have suggests that, you know, the study that I showed you before is relatively consistent with other fatal overdose events. So I've got a couple of references listed here. That's not to say that all overdoses that occur while someone is alone result in fatality, and that's certainly been shown in other studies. But it definitely raises the risk of fatality if you are alone, you overdose, and no one is there to kind of respond in a timely manner. And that is why in many public health campaigns, we see these recommendations like never use alone. So this is one, this is an infographic and kind of public health campaign that I love from Be More Power in Baltimore. And as you see, number 3 is never use alone, kind of recommending people to just avoid that altogether. Well, we know that there's a lot of good reasons that people use alone. In the last couple of years working on this topic, I've realized that, you know, there's a lot of drivers of using alone that are going to be hard to combat with a public health recommendation that just says don't do this. So some reasons that I think someone might be unmuted. Should I a question or anything? Okay, I can't see you all, so please stop me if I should stop. So really quick, just some of my previous work, thinking through like what might be some barriers to adopting this behavior of not using alone ever, are stigma. For example, in a past study that I was part of, we found that enacted stigma, so discrimination or mistreatment, was a predictor of overdosing in the past year. And this really extends when we think about using alone as well. A more recent analysis using data from Michigan really showed that fearing or anticipating stigma from others was associated with using while alone more frequently. So it's not only associated with the outcome of overdose, but also with using while alone. There's lots of other reasons that people use alone. Stigma is certainly one that's supported in qualitative research as well, but also from other qualitative studies, this one being in Baltimore, people often highlight this issue that, you know, if I'm not using by myself, then I'm going to have to share my drugs with someone, and I don't have enough money for that. So there's really some kind of financial rationale and constraints there. And then there's this fear of criminalization as well. So this is obviously not a study, it's a tweet on the right-hand side here, but I thought it summarized the point a little better than a study could. So someone says, some people in harm reduction say, don't use drugs alone, just do them outside next to a cop. So really highlighting like there's some very practical barriers to people just kind of changing their entire behavior on drug use. And, you know, that's why these recommendations to not use alone are probably insufficient to, you know, helping people kind of think through what strategies they could actually use when they do find themselves in a situation where they're alone. So some of my other work has really tried to figure out like how often do people use while they're alone? Like what chunk of the drug using events are we talking about here that they would need to kind of adopt some safer use strategy? And so this is data from a study in Michigan. And in this study, we looked at people who had used heroin and people who had misused opioid analgesics separately. And not, you know, kind of to my surprise, found that 70% of those who used heroin said they used while alone very often in the month before they attended a treatment program, and kind of a similar percent of those using opioid analgesics. This is not wildly different from other studies. Other estimates range from around 7 to 81% of people who use drugs say they use while alone, and that really depends on the population studied. Most are towards kind of that, I would say like mid to upper range. The 7% is actually a study of veterans that is interesting, but I think really different from some of the other ones. So certainly, you know, I think asking people about this behavior is something that's warranted to kind of understand like, you know, open a conversation, I guess, about what strategies they might need to use and how commonly they might need to be using these strategies. In the paper that I just mentioned, another thing that we looked at was whether people who used while they were alone also reported other overdose risk behaviors, with the idea that if we kind of understood what people were doing while they were using alone, maybe we could sort of do some counseling around spacing out you know, drugs that have known drug-drug interactions, for instance. So in this study, I'll just kind of go super quick through. We found that those who had misused opioid analgesics, if they said they used alcohol and opioids within the same 2-hour period, they were also likely to say that they were using while alone. People who said they used benzos and opioids were also more likely to be using alone, and this was regardless of whether they were using prescription opioids or heroin. And then same kind of association with using in a new setting or a new place. And so certainly some concerns, but possible areas where people, you know, could make some safer choices in those times when they were alone. So I guess kind of in this last part of the talk, I figured I would just talk through some of the newer research that I've been working on, thinking about how might we be able to minimize fatal overdose risk among people who use opioids while they're alone, and kind of make those settings of solitary use a little bit safer. Before I get into that, I kind of wanted to talk a little bit about safer injecting facilities, also known as overdose prevention sites. These are really like the brick and mortar version of a safe space where you could go to use. You can go there alone, but there are staff around who can observe and make sure that you don't overdose, respond in kind, provide safer injecting equipment, provide referrals, all kinds of things. Unfortunately, we don't have a lot of safer injecting facilities in the US. New York City recently opened one in the pandemic, which I believe is still operational, though I know several others have tried to open in the past, and the legality of those has been very complicated in the US. So hopefully more coming soon, given the success in New York City. Since that one is newer, a lot of the evidence that we have about how safer injecting facilities reduce overdose risk is from studies in Canada at Insight, which is Vancouver's first safer injecting facility and the first one established in North America. And what this table is showing you is that overdose risk or overdoses decreased about 35% between the time of before the SIF was implemented and after. in the area that was pretty close to the SIF, so probably where people were going, versus, you know, not too much change and not a statistically significant change in areas outside. So really kind of pointing to this evidence that safer injecting facilities really can reduce overdose risk. So in this time where in the US, we don't really have the ability to establish a safer injecting facility everywhere, and really we probably won't get to a time where there is a safer injecting facility everywhere in the US that's accessible to everyone. We don't even have syringe service programs that are accessible to everyone yet. So kind of thinking through like what other ways we could kind of fill these gaps. One might be around technology. And so I want to talk a little bit more about that. The kind of on this slide, from simplest to most complicated, there are lots of ways technology might be able to help us. One is kind of these alerts of a bad batch, which they have operational in Baltimore, that kind of alert people whether the overdose rates are spiking in the last couple of days in their area, just kind of warning people like, hey, the drug supply might have, you know, more fentanyl right now. Two that we'll talk a lot about in the next couple slides are Never Use Alone and the Brave app. These are overdose detection services. So Never Use Alone is a phone number that you can call, be on the phone with someone while you use drugs, and then if you lose consciousness, they will facilitate an emergency response in your local area. And then Brave is kind of the same thing, but it's a smartphone app. And you can, and with Brave, you can also identify someone who is kind of in your life who you want to be notified rather than EMS. And then something I won't really talk much about today, but I think is cool, but I haven't seen the implementation on this, is passive smartphone-based respiration monitoring, and which in theory could be paired with an emergency response as well. So just kind of getting back into our work here in Wisconsin, in the kind of, I guess it was early 2021, there was a call for campus awards for COVID-19 related studies. And at the time I was just starting to work with Ryan Westergaard, who I work with quite a bit more now, but this was sort of at the beginning. And he had just done a COVID-19 impact survey of people who inject drugs in Wisconsin who were visiting syringe service programs run by Vivint Health, and really found some concerning trends that might be related to the increases in overdose mortality in Wisconsin, namely that people said they were using alone more often during the pandemic, many were overdosing, and that they were kind of had this general feeling of anxiety, depression, or loneliness, which could all kind of increase overdose risk. So we decided to write a grant, which was luckily funded through the Wisconsin Partnership Program in September, I think our grant started. And we have since named this the I Thrive WI study. I'm not really going to talk about AIM-1 today. It's an epidemiological characterization of overdose and COVID-19 among people who inject drugs, but more focused on AIM-2, where we are hoping to develop a mobile health intervention to reduce overdose risk. And that involves Never Use Alone and Brave, which is kind of how it ties to the previous material. So I just want to quickly acknowledge our wonderful study team on this project. Ryan co-leads the study with me. Katie Migel, who I know is on this call and facilitated my name being pronounced very well. Thanks, Katie, and a number of other wonderful people. And we are also partnering with Vivint Health to do this research. So yeah, just quick a bit about how I Thrive WI will work. It's a mobile health intervention to reduce overdose risk, and we have kind of a secondary goal around supporting COVID-19 vaccine uptake. And so this was really a project that was modeled after an in-person, it's called a prevention navigation intervention, which is a study that Ryan is leading now, that kind of facilitates people setting health-related goals and working on them over a series of a couple of months. And so what we were hoping to do is figure out, can we adapt some of the overdose prevention elements to a smartphone based platform, and then deliver that content and monitor whether any overdose risk behaviors change. So the way the study works is, and recruitment will probably start this summer, but just to kind of give you a quick idea, there's an enrollment with some surveys, and then they go through 12 weeks of kind of this self-directed goal setting on a smartphone. We do communicate with participants as well because we give out smartphones in this study, which are actually, I don't know if you can see the boxes, but they're sitting behind me. And so they spend 12 weeks kind of picking different aspects of overdose risk that they may want to work on, and then kind of setting one thing a week that they want to try out. And then afterwards at months 3 and 6, we'll do some other surveys, again, focused on overdose risk behaviors that may have changed. And so our primary outcomes are feasibility. This is for our kind of larger team, one of the first studies where we've given out smartphones. In previous studies, participants have reported like not having great access to smartphones. So we thought, you know, in this study, we're really kind of try to encourage people to educate themselves, to do things like call the Never Use Alone hotline, et cetera. So we really need to give them the tool, the phone, and the data plan to be able to make those changes. So again, many outcomes around feasibility, acceptability, and then we've got some secondary outcomes around overdose risk behavior changes, and COVID-19 vaccination, some of which are around, you know, how often did you call the Never Use Alone hotline? How often did you use the Brave app, and that sort of thing. So I'm excited to see if people, given that they have access to these technologies, actually might use them. And I'm almost done here, but just to kind of wrap up, as I said before, using law alone is just, it's one of those, it's kind of an overdose risk behavior that I think a lot about in my research and kind of try to understand and figure out, like, are there creative ways that we could kind of help people reduce harms in this situation. And so kind of back to the original, the naloxone study that I talked about, in those patient interviews, we actually did ask people, how often do you use while you are alone? Just to kind of try to get an idea of how sufficiently our, you know, supplying naloxone was going to cover some of their drug using episodes. And people really said, as in other studies, most of my using is alone. That's the first two kind of quotes here. Many times driven by stigma or embarrassment, shame, trying to hide, which is highly consistent with other studies. I was encouraged that some participants also, you know, said, like, there is someone that I trust that I use with. This person in the third quote, it was their wife. But at the same time, there's kind of this potential risk because this person said, you know, we use at the same time, we don't stagger. So I think there's a lot to be done to kind of recognize, like, what risk scenarios are coming up. We also, because I really, you know, have kind of an interest in figuring out, like, are some of these new tools feasible? We also ask people about overdose detection services. So we ask people, you know, have you heard of this, you know, thing called Never Use Alone, yada, yada. So this is just one person's kind of reflection on that, where the facilitator says, you know, have you heard of special services to make using alone safer? There's a new app called Brave. There's an overdose safety line. And most of the participants said, no, I have never heard of that. The reaction to those, and I'll show you more on the next slide, were kind of mixed. This person in particular said, you know, I actually, you know, I get that. And that's something I've even done before. You know, I've called someone who knows that I'm using, and then they can check on me. So it's certainly not a far off strategy from what some people are using. At the same time, we know that people have really good reasons to distrust or have hesitations about something new, like an overdose detection service, especially where, you know, you're asking them to share really private information about your location to facilitate the emergency response. And so here's just a couple of quotes when we asked people, what hesitations would you have about something like this? And so people said a number of different things. One is, the top quote is really this idea that, you know, what if somebody saw that I had the number, they might know that I'm using. The second hesitation that really came up was around kind of sharing with someone on the phone that you're using, and that just feels like something you wouldn't trust. Though they did kind of make an interesting comment at the end about there's a lot of people trying to change what's going on in our culture with opiates, which I thought was interesting. And then third, and really not surprisingly, you know, people really worry about being charged with a felony. or other crimes when there's drug paraphernalia around or they're found to have overdosed. And, especially if that's on top of other prior legal troubles for them. So certainly some barriers to people using these overdose detection services, and really just not a lot of awareness that they exist just yet. So just some next steps to mention here as I wrap up. Never Use Alone has kind of become like just a little more interesting to me as I've written a few grants, and I've been in our iThrive WI study, we really wanted to provide people information about this, especially because we're giving them phones. And so one thing that we did was reach out to the founder of Never Use Alone and just kind of say, like, what would you want us to tell people about your service? And then as we've kind of gotten on to talking, have also talked about maybe doing a new project where we survey people who do call Never Use Alone, kind of try to understand why they're calling, when they're calling, how they're using the service, how often they're using the service. So that's a study that I'm kind of just getting started with a doctoral student here in nursing that I'm excited about. And then there's a couple of other new grants that have just gone in as well, which will hopefully kind of formalize some partnerships between Never Use Alone and Brave as well if they're funded. So lots of new stuff going on, and hopefully, more and more data to share in the next year, but that's kind of what I have going on right now. And that is all that I have. So I can take any questions if there are any, and it was just great to share with you all.